Hello, I'm Dr. John Feller, the Chief Medical Officer with Halo Diagnostics, and these are my disclosures. I'm going to be talking about the emerging role of radiogenomics, so the combination of advanced imaging, especially multiparametric MRI, and other biomarkers such as tissue-based genomics for the diagnosis and risk stratification of therapy for prostate cancer. In terms of context, Halo Diagnostics is an outpatient advanced diagnostic center network. We do community based research, and this research is centered on combining advanced imaging with other biomarkers and machine learning, artificial intelligence solutions. The pertinent clinical trials in this presentation are shown here. I'm really going to focus on the emerging role of radiogenomics, specifically its role in risk stratification for focal therapy. Some background information: we have an ongoing phase 2 clinical trial. It is focused on outpatient trans-rectal MR-guided laser focal therapy. We presented the 10-year interim results this year at the AUA and published them in the Journal of Urology in the supplement. The study is an IRB-approved trial using 510 cleared software and hardware technology. We do outpatient transrectal MR-guided laser focal therapy under MRI guidance using real-time MR thermometry. This is a true focal therapy protocol where our goal is to eliminate the MRI abnormality plus a 1 centimeter margin. We've treated a total of 291 cancer foci in 181 patients beginning in 2010 through 2020. All patients undergo an MR-guided in-bore biopsy of the treatment site at 6 months and then have yearly MR-based active surveillance follow-up. We follow the serum PSA, the PSA density, the multiparametric MRI findings, and then also patient-recorded outcome measures, including the International Prostate Symptom Score, the Sexual Health Inventory for Men, and then a mental health PROM, the PHQ-9. We have 2 limbs in the study. 85% of the patients are treatment naive, and about 15% are salvage patients. If we look at the biopsy results over 10 years of the treatment site and any incidence focus of tumor suspicious region on the follow-up multiparametric MRIs, we see that overall marginal in-field recurrences at the treatment site have developed in 21% of our patients, and incidence foci of clinically significant prostate cancer that are out of field have developed in 4% of the patients. If we look at the serum PSA in the treatment naive patients at 1 year, it drops by about 37%. And if we look at the PROMs, there is no statistically significant urinary incontinence at 1 year, no statistically significant erectile dysfunction at 1 year, and no significant mental health issues that develop at 1 year following the MR-guided laser focal therapy. So the functional outcomes are really outstanding. If we look at the oncologic outcomes with Kaplan-Meier survival curves at 10 years, we've had only 1 case of metastatic disease from prostate cancer, so the metastasis-free survival at 10 years is 99%, and we've had no prostate cancer-specific deaths, so the cancer-specific survival is 100% at 10 years. So to summarize the findings from this phase 2 trial looking at laser focal therapy at a 10-year interim evaluation, 95% of our patients have undergone biopsy of the treatment site at 6 months. They all have MRI-based active surveillance for 10 years. Clinically significant in-field recurrence rate or marginal recurrence rate was 21%. Clinically significant out-of-field recurrence rate or incidence foci of cancer was 4%. No statistically significant erectile dysfunction or urinary incontinence at 12 months. Only 6% of our patients had to be converted to whole gland therapy during the 10 years. So 94% were able to avoid whole gland therapy and the associated morbidity, which is, erectile dysfunction in the 50 to 70% range and urinary incontinence that can be as high as 15 to 20%. Metastasis-free survival, 99%. The prostate cancer-specific survival, 100%. And we were able to obtain short-term and intermediate-term oncologic control in 79% of the patients with the initial treatment. In the patients who did have marginal recurrences or out-of-field recurrences that were still intermediate risk, over 90% of those patients elected repeat MR-guided laser focal therapy and are doing quite well. This oncologic level of control compares very favorably to the biochemical recurrence rates for radical prostatectomy and radiation therapy for organ-confined intermediate risk prostate cancer, which is over 20% at 5 years and over 30% at 10 years. Now, one of the questions with regard to radiogenomics that we embraced was whether or not it could be used for risk stratification for focal therapy. So we asked the question, can responders to focal therapy for prostate cancer prospectively be distinguished from non-responders using biomarkers? We defined responders as those patients that had a negative MR-guided biopsy of the treatment site following the focal therapy and that do not develop either in-field or out-of-field clinically significant recurrences. And we defined clinically significant as grade group 2 or above, so anything with Gleason pattern 4 disease. These are some of the different factors that we looked at for the possibility of risk stratification for focal therapy: age, initial serum PSA, initial PSA density, index lesion, multiparametric MRI tumor volume, index lesion quantitative ADC, Gleason score, tissue-based genomics, liquid biopsy, and then bringing into play molecular imaging such as PSMA, PET-CT. First of all, looking at age, notice comparing the responders here in blue with the non-responders, there really wasn't a significant difference between them based on age alone. If we looked at serum PSA initially, there was a difference between the mean serum PSA in the responders compared with the non-responders. Similarly, if we moved over to evaluate PSA density as a biomarker with a growing body of literature suggesting the importance of PSA density, we found that if we compared the responders here in blue, the mean PSA density initially was significantly lower than the mean PSA density in non-responders. Interestingly, looking at the index lesion MRI volume, so the tumor volume measured with MRI, there was really no statistically significant difference between the responders here in blue and the non-responders, unlike would have been suggested by the early work by Tom Stamey in the 1980s that showed that tumor volume, at least at surgical pathology, had a high correlation with prognosis and was a very important biomarker after the Gleason score. Moving over to tissue-based genomics, initially we evaluated our focal therapy patients with just P10 and ERG, but transferred that over a number of years ago to using Decipher for biopsy and the Decipher score, and then also a research use only tool, the Decipher grid. It's well known now in the literature that heterogeneity for prostate cancer is not just limited to its histology. Also, the genomics are struck by heterogeneity. So the importance of the quality of the cores and the type of guidance that's used for doing the biopsy is more and more being realized, and MR-targeted biopsies probably are going to emerge as a front runner for making sure that we have appropriate representative cores for determining the genomic risk. If we look at all of the patients that we've done MR-guided in-bore biopsies at Halo Diagnostics over the last few years, that we also ran the Decipher for biopsy test on, which is a total of 100, not surprisingly, as we go from grade group 1 to grade group 4 here, you can see there's an increase in the percentage of patients that have a high Decipher score and high genomic risk. Also, there's a decrease in the patients that have a low Decipher score or low genomic risk. Interestingly, in the grade group 1 patients, and remember, all of these are MRI visible in our cohort for focal therapy, that as many as 10% of these patients that have MRI visible grade group 1 disease have high genomic risk based on the Decipher score. If we look at the Decipher score in responders versus non-responders, you can see that the mean score is lower in the responders than it is in the non-responders. Using the Decipher grid, which is a research use only tool that tests for the entire human exome, we've been able to do some very interesting heat map analysis and demonstrated that if we compare responders here in brighter green to the darker green non-responders, there are 20 genes that are upregulated in the responders and downregulated that flips in the heat map when compared to the non-responders. And this is going to be an area of very interesting research, I think, in the risk stratification space. Moving over to liquid biopsies, we utilize a blood sample and the Biocept test to look at circulating tumor cells and circulating tumor DNA, and then a urine sample for ExoDx, looking at exosomes. The circulating tumor cells and circulating tumor DNA are measured from a blood sample using the Biocept test. At Halo Diagnostics, the patients that are in our focal therapy cohort, 75% of them that we've tested so far have circulating tumor cells that were detected, and only 25% of our cohort showed no detection. As we go from grade group 1 through grade group 5, not surprisingly, the percentage of patients that have circulating tumor cells goes up. But it's interesting to note that 25% of the patients, again, that have MRI visible grade group 1 disease also have circulating tumor cells. We have some interesting cases in this space. Here's an example of a patient who, following MR-guided laser focal therapy, still had circulating tumor cells detected at follow-up, despite the fact that their MR-guided in-bore biopsy of their treatment site was benign, and there was no MRI evidence of out-of-field recurrence. So important to remember that no circulating tumor cells are ever found in the serum of cancer-free individuals. So it'll be interesting to see over time what the follow-up of this type of patient means. Here's another interesting example. Here's a patient who pre-laser focal therapy had circulating tumor cells detected. The number of cytokeratin negative circulating tumor cells was 45 in this patient. And then following successful MR-guided laser focal therapy, no circulating tumor cells were detected, and the number of cytokeratin negative circulating tumor cells went down to 0. So this may be interesting to study as a definition of minimally detected disease, possibly even being useful as a new definition for biochemical recurrence in patients that are in focal therapy trials. So in summary, with regard to radiogenomics, multiparametric MRI followed by genomics and other biomarkers show promise for risk stratification for focal therapy of prostate cancer. Research of radiogenomics in the setting of focal therapy of prostate cancer may help to develop novel combination therapies that include focal therapy combined with checkpoint inhibitors, immunotherapy drugs, or possibly even oncolytic virus therapy. And also the multiple complex data sources from the advanced imaging in these biomarkers, I think, present a very interesting artificial intelligence and machine learning opportunity. And just to end with an example of that, this is some development work we're doing at Halo Diagnostics using AI and machine learning for segmentation, cancer probability map development, and focal therapy based on the multiparametric MRI data. So here's an example of machine learning algorithm being used to successfully segment the prostate gland on a T2-weighted axial image. Here's an example of the cancer probability map, with the green being sort of very low likelihood of prostate cancer and red very high likelihood of prostate cancer. And you can see a high risk high probability area here in the left peripheral zone, and a more intermediate probability here in yellow, detected by the machine learning algorithm in the right peripheral zone. And an MR-guided inbore biopsy of this proved clinically significant prostate cancer in the left peripheral zone, grade group 2, and proved that this intermediate probability on the right, according to the machine learning algorithm, actually represented acute inflammation and not prostate cancer. Finally, I'd like to recognize the HALO Diagnostics research time and really thank you for your attention.